Welcome to the Mindset Matters, the podcast where psychiatry, medicine, and real human experiences collide, all through the eyes of two psychiatric PAs.
We're your hosts, PA Mercedes Dodge and PA Jessica Spissinger, two passionate psych PAs on a mission to bridge the gap in mental health care.
So whether you're a provider just here to level up your psychiatric insight, increase your mental health skills, you're in the right place.
Each episode, we shine a light on the incredible work PAs are doing in psychiatry and beyond. Our goal is to build a community focused on better patient care, professional growth, and personal well-being.
This podcast, a little disclaimer, is for educational purposes only. We're not here offering medical advice, psychiatric advice. If you or someone you know needs support, please reach out to a licensed mental health professional. All right, guys, let's dive in.
All right, so this is our first mini mindset podcast accompanying our podcast Mindset Matters. And this is where Mercedes and I geek out over all different psych topics. The one I've chosen to start with is tricyclics. How do you feel about that, Mercedes?
I think it's awesome because I think there's a lot of people that are not really using it and they need to know when to use it and what are the things to watch out for. So I think this is a great dive.
Yeah, and we were definitely going to dive because I went into some little rabbit holes along the way. For me, why I chose tricyclics is they're kind of about as OG as it comes when it comes to psychotropic medications outside of the antipsychotics. The big things that are always so important to know about tricyclics is that they can be lethal in overdose. 6 times the therapeutic dose, which means equivalent to 6 days worth of treatment, depending on which class, can potentially be fatal. Over time, as the SSRIs came into view, the tricyclics were really phased out with situations of depressants. And now we really consider them more for treatment resistance and a lot of other things that they're used for, which we'll go into. Even though we don't think of them as first line in psychiatry, they are used in so many other non-psychiatric indications that you will see them again and again. You need to always kind of have that radar attuned to what is going on with them, because I still consider them one of our main meds to monitor. And they are interesting. So do you know much about the history? Has that ever been something you've looked into?
No, I have not. So please walk me through this place of history.
History for me is the most fun part. I get super excited about it. And there's more spinoffs to go into beyond what we'll do today. When the tricyclics came into play, it was on the brink of a turning point in psychiatry. The sanatoriums or asylums. Some of the treatments were emetics, laxatives, hydrotherapy, which is not done in a nice way that we may think of today. With Freud came psychoanalysis and psychotherapy. There just were not a lot of options for treatment for depression and other mental illnesses. But before that, grand mal seizures for therapeutic use were induced by chemical agents. Because they didn't have like the anesthesia that we have today, we couldn't put people into a paralytic state and there'd be broken bones and fractures and all sorts of uncomfortable, you talk about side effects, like uncomfortable consequences. And so you can understand why ECT has a pretty notorious reputation. We've come a long way, ECT, another interesting spinoff to do. Have you ever heard of some of those elements of the history, like the hydrotherapy and emetics?
No, I haven't. I was trying to think about what can I ask today that will add more, and you're already adding more without me doing anything because I did not know this.
So a little bit more of the history is that setting the stage, there was really no psychopharm. And the first real psychopharm that came in outside of like opioids and alcohol would be investigation of the histaminergic agents like antihistamines. It was through the process of seeking out different antihistamines that we eventually landed on both antipsychotics and then the tricyclics. The reason there was a big push to look for antihistamines was because of the inability for people to do ECT or chemically induced convulsives, but also surgical options where people would go into surgery, understandably, very anxious and nervous. A lot of the surgeons were looking for something for pre-surgical anesthesia. They found that Benadryl came along in the 40s and then all the other antihistamines. And by 1950, there was at least 20 antihistamines that were marketed. So you can see our little friend there, hydroxyzine, 1956. It's kind of the favorite one of the day right now. So they mentioned there was the search for sedation. They're looking for strong sedation medications. And this French surgeon, Pierre Huguenard, combined promethazine with this other chemical called pethidine for the pre-op option. And what Henry Labouré noted is that it was causing this reaction of what he called sedation without narcosis. Narcosis. I had to look this word up a couple times. Have you ever seen this word? Because I'm like, is it neurosis or is it narcosis? But it's narcosis.
Narcosis.
I know. It's interesting. And it's basically a word that describes the condition of stupor or unconsciousness or delirium. So people were kind of in this reduced sensorium state. And it was this chemist, Paul Charpentier, who further developed this derivative of promethazine into chlorpromazine, which became what we know now as thorazine. And that was the first antipsychotic into the market. And so these are all phenothiazide derivatives. Phenothiazide is like this organic compound. It is essentially related to this thiazine class. If you really want to geek out in your chemistry, I'm not really going to go there, but just to say from it, a lot of different derivatives came. Methylene blue with a big discovery that helped stain slides to look at bacteria. And then the specific agent, the phenothiazine, was used as like a dewormer and like an insecticide. Promethazine, which I just mentioned, came about as the antihistamine in the 1940s. And then from there, the promazine was another derivative of the phenothiazine. So is this all like
brand new? I mean, all I know is really about when to use tricyclics, when not to use tricyclics, and what to watch out for. But it's interesting is that the history was asking something that wouldn't cause a patient to be so lethargic and under the influence. And it's interesting because now we have so many medications and all of them have side effects, and we're trying to find that balance. So it's an old medication that has history for helping in particular cases. And I think we're trying to find what cases it would be helpful for. So it is interesting, the history.
When you think about how harsh the treatments were prior to meds, sometimes there's a sense in psychiatry that we're trying to over-medicate people, but it's important to appreciate how much medications have helped throughout time. It's fascinating that back in the 40s and 50s, like there were not the protections of like the FDA, and DEA like there are now. There's no requirement for double-blind, placebo-controlled trials. So they were like, here's this chemical, let's try it out on a patient. Lots of abuses of informed consent back in the day. But they led to chlorpromazine. And what happened with chlorpromazine is it's the first antipsychotic medication that really made dramatic effects for people with schizophrenia, with bipolar. And it was revolutionary at the time that it led to this huge race to develop other antipsychotics. And that's a story for a different day. But this is where our story deviates from this race to develop other antipsychotics. The first tricyclic came out, a chlorpromazine type derivative. And they noted that when given to patients pre-op, the patients were not becoming sedated and calm and tranquil like they had been with the antipsychotics. Instead, they became almost like manic. They were excited, overactivated, and agitated. It was very quickly realized that this medication was having a very different effect. A single case study came out of a woman who had demonstrated some antidepressant effects in response to the imipramine. I looked and I was like, I want to find this woman. I want to know who is this woman, case X, that was like tried out the imipramine. I'm sure that's an interesting story.
Yeah. And I wonder if anyone can find the case report.
I was looking. I'm sure it's out there with a little more time. Maybe one of our listeners could throw it up for us. So this became essentially a breakthrough with the option, like we had the antipsychotic. Now maybe there's a medication that can help this depressive psychosis. And you think about patients at the time kind of languishing in asylums, now had this medication that was causing like this awakening. But when you think about those patients, this was not necessarily someone who's like generally like functionally going about day to day in society. Most likely this woman was an asylum-based case and probably with the melancholic depression.
Yeah.
So like what the symptoms were that the imipramine targeted was that apathy, that psychomotor, or what they called like a kinetic retardation, hopelessness, despair. Those improved about 30% as they went on to do further studies. They noticed about a 30% improvement, which continues to track with what we see today. And then there was like the above and beyond of the manic inducers where somebody had a latent bipolar that was not known. They were in a depressive episode, took the imipramine, and then became manic. So there was interesting reactions there, right? So then it became like another race. From there was an unfolding of a lot of other tricyclics. I want you to look away from the screen, Mercedes. Tell me the names of as many tricyclics as you can think of.
Oh my God. Amitriptyline.
I know, I'm putting you on spot now.
You are. I mean, like, there's so many. It's all the things with the leans.
Lots of leans.
Amitriptyline, nortriptyline. Those are the ones I really use, to be honest.
Yeah,
That's
like
all
there's
I
only
do.
a handful that we really see. So you can look at the screen now and you'll
Okay.
see I've got about, what is this, like 18 here.
That's a lot. I don't think I knew all that.
Yeah. Some of them were like developed, they were marketed and used
Doxepin, I
in
know
like
that.
Europe, and then they're
Mhm.
like not anymore in circulation, or they're only used in Europe, not America. They do have that like same like imipramine, desipramine, clomipramine, amitriptyline, nortriptyline, protriptyline, doxepin. Somebody got off the beaten path there. Bituprylene, dimetricrine, lofipramine, meltraxen, nitroxazepine. They're not flowing off the tongue anymore. As you point out, there's definitely just a handful that we use. I have the slide that shows the chronology. So, if you think of like 1950s really being the great expansion of the antipsychotic, the 1960s was the expansions of the first antidepressant agents. Fun farm facts. So like chemical, molecular structure, mechanism of action, all that. All right. You with me? Did I lose you?
Yeah, I am. No, I just I can only recognize 3 on that big list of medications
I know.
that I
But we're going to
use.
circle back to that, and you will find that there's probably a few more that just
Maybe.
didn't pop up in your mind at the time. I'd say there's about 5 that I do see fairly regularly to some degree. Oftentimes, they're still the outliers. Bare bones, chemical structure information. Tricyclics are so named because they have these 2 benzene rings, which are connected by a 7-member central ring forming a 3-ring structure. So that's just all essentially this atomic chain is making a ring. The configuration helps its rigidity and it makes it biologically active. It kind of like preserves its shape and structure. That side chain with the amine group is essentially what extends out from the central ring and ends in either a secondary or tertiary amine group. That part is important for the mechanism of action because that's where the specific pharmacological effects come about. So remember all that good old organic chemistry we had to take before beginning school? Yeah. It's not really our day-to-day vernacular, but for those who want to know, there it is. Mechanism action, this is more of our lingo these days. We've got lots of different playmates with the tricyclics. We might not always think of that. We might just think of the serotonergic, but we've got other neurotransmitter impacts. So we've got our friends, the 5-HT2A, 5-HT2C, and they're inhibiting the presynaptic neuronal reuptake of norepinephrine and serotonin in the CNS by blocking those receptors. So you could almost think of tricyclics as sneaky SNRIs.
That's
Because
a
they
great
are
way
not,
to think about them.
right?
You're right.
And like they're not just serotonergic. Like, I tend to find that we think of them more as in the serotonergic family, but it's important to remember that they're actually quite norepinephrine inducing as well, which plays into their side effect profile. In addition, they modulate presynaptic and postsynaptic beta adrenergic receptors. So that's where we're starting to talk about the cardio side effects that are related. And of course, what they're kind of most famous for is all of those histaminergic and muscarinic cholinergic alpha-1 adrenergic receptors. And that's where we get all of those really yucky side effects that are problematic, but sometimes used off-label in helpful ways. All right. So we talked about subclasses. And so these might start to kind of pop out at you more. So the tricyclics are arranged into their different groups. Let me go back to the slide. So the tertiary amines, that group has like the 2 carbon chains that are attached to nitrogen atoms. And these are the ones that are going to have the stronger anticholinergic effects. Here, you're going to have more of the serotonin reuptake inhibition. Okay, so there's going to be more serotonin flow. For secondary amines, there's going to be the 1 carbon chain attached to the nitrogen versus the 2. And here, the secondary amines are going to be better tolerated, and you're going to have a little bit more inhibition of the norepinephrine reuptake. Here they are organized by groups. And so we've got our amitriptyline. For the tricyclics, I always know the generic. It's always the brand I have to look out because the brands are so old, like they're pretty much never used. Clomipramine, that one rings a bell, of course. And imipramine is the OG, so just never forget it. I don't think it's used very often. It is still there. Moxapine, desipramine, nortriptyline. I definitely see nortriptyline a lot here and there. Do you see it? Yeah.
Yeah, I do.
So this slide looks kind of weird, but pharmacodynamics. So overall, speaking grossly broadly about all the tricyclics, they're well absorbed in the GI tract. They're generally subject to significant first pass liver metabolism before they go into systemic circulation. They're largely protein bound. There's range. They're highly lipophilic with large volume of distribution. And they're extensively metabolized with hepatic microsomal enzymes with pharmacologically active metabolites. And that's where we start to get into our pharmacogenomic impacts, which we'll talk about with level adjustments. Some of the most famous adverse effects are due to the different neurotransmitters and the histamine receptors. We've got sedation, weight gain, anticholinergic effects are going to be those blurred visions, the dry mouth, constipation, urinary hesitancy, and retention. That's where the cardiotoxic effects also can occur, sexual side effects, and then the alpha-1 receptor blockade is orthostatic hypotension. And it's much more complex than this, but these are the ones that always stand out with us the most. When you think about the side effects of tricyclics, are there any of these in particular that you tend to see the most?
I think the anticholinergic side effects is where I think most of the concern is. And it's, we think of it as dry as a bone. We learned that in PA school. One of the things is patient education. When I'm talking to patients starting a tricyclic, I ask, how is everything going with hydration? What's the diet? How their bowel movements are going? I think we as PAs and medical providers really need to know their baseline of like how things are moving along and then deciding whether it's the right medication, which I think you're going to go into about the cardiac, because that's one of the things you got to screen when you're thinking about starting this medication.
100%. And that's what we're going to talk about next, like contraindication. When I first started working at the psych PA, psychiatrist that I worked with said to me that if you prescribe tricyclic antidepressants to a patient with suicidal history, suicidal ideation, that is 100% malpractice suit. Look out. Do not ever do that, right? That was huge. And I think about that and it always stuck with me because who wants to bring that on themselves? But, then it occurs to me how much they're used in other fields these days.
And so do you think that those specialties and those offices are asking suicidal risk?
Just as the concern as it almost starts, as the tricyclics start to depart psychiatry and work their way into other fields. So there are these like contraindications. There's bifascicular heart block, left bundle branch block, prolonged QT interval, narrow angle glaucoma, prosthetic hypertrophy, and of course the acute suicidality because of all of these cardiotoxic effects. So if somebody has a pretty significant cardiac history, if they have glaucoma, if prosthetic hypertrophy is a problem, thinking about the urinary impact, these medications are likely not going to be great options for the patients.
Yeah. So my question is for our listeners, what is the perfect patient? Obviously, there's no perfect patient, but what would be the perfect patient for something where tricyclic would be, I should consider it? And for me, I think the top things is young, like under 40, under 50, maybe with no cardiac issues, who's tried several medications or sensitive to other medications like the SSRI and SNRI and is depressed. That cognitive depression, that cognitive doling, that's who I think of when I think about tricyclics.
Yeah, definitely someone who's got a less complicated psychotropic profile so that you're trying not to be slinging multiple meds at someone on tricyclics so you can kind of keep the field clear because there are a good amount of drug interactions. Depending on the different medication, there can be an increased anticholinergic burden, more antiarrhythmic activity. It can be vasodilators and hypertensive agents can be problematic. Too much serotonergic load with multiple combination agents like SSRIs can be done, but it has to be done cautiously. And then, of course, avoid with MAOIs because we just don't do it with their lives. In general, if somebody has an antipsychotic on board, especially the first gens, it can increase tricyclics in levels 30 to 100%. So think about how vulnerable these medications already are to toxicity. Cimetidine, which is an antihistamine, which I've never really used much, but I've heard some good stuff with, which we kind of spin off for another day. And methylphenidate, that is going to lead to tricyclic increases. Some of the 3A4 inhibitors, like the antifungals, calcium channel blockers, and the 2D6 inhibitors, like again, SSRIs, and particularly fluoxetine and paroxetine, they're going to cause some more trouble with the tricyclics as well. So it's important to keep those in mind. Whereas other medications like nicotine agents, like cigarettes, can actually cause the tricyclic levels to decrease. So suddenly maybe the meds are having good effect and now they're not. And there's just kind of a handful. And they're not ones we see that much, like carbamazepine, phenobarbital. We're not commonly prescribing those outpatient. Carbamazepine is certainly still in the picture, but fading out. But certainly we see plenty of alcohol and cigarettes in the picture.
I mean, I always like to mention when we're taking a good history is that we should be collecting nicotine use, alcohol use, all of these commonly used recreational substances that we don't think it plays a factor in what we prescribe, but it does.
So I've got some more slides going over some warnings, things to keep in mind with hypertensive agents, vasodilators, more details like what we covered, the antiarrhythmic and cardiotoxic concerns. But I just want, before we wrap up, I just want to kind of go over what I call our TCA all-stars, because these are the ones that we still see commonly. Doxepin, clomipramine, has its great points, nortriptyline, amitriptyline. I put together this slide here for reference. It has the dose ranges, the FDA clinical interactions, the off-label uses as well.
My summary of the all-stars would be clomipramine, think of OCD. Amitriptyline typically is something that can help with insomnia, as well as doxepin if there is comorbid insomnia, which is a complicated topic. And nortriptyline, think of it for elderlies. It's more tolerated. Those would be my summary slide for the table that you had.
For me, it's like doxepin. When it works so well at these teeny tiny levels for sleep. The sleep dosing is always roughly 10 milligrams and under, at 6 milligrams of doxepin. Sometimes that generic 10 milligrams of doxepin, the person can open up the capsule and do 5 milligrams if they want to, if the 10 isn't doing it. With doxepin and insomnia, less is more. Clomipramine can work so well with OCD. It actually can work better than the SSRIs. It's just a matter of the tolerability. I have a patient that was doing so well on it and having an improved response, but had really debilitating sexual side effects. And of course, we include that in the mix, but we don't always think about tricyclics and sexual side effects. We tend to think more of the SSRIs and SNRIs. So just don't forget that. And they have their uses when they work. So takeaways, tricyclics, still high risk. There's a narrow window of use, but when they can be used, they're good. With tricyclics, they're old school. We got to respect our elders. We got to recognize their place in history, recognize that they have so many different impacts on different neurotransmitters. They can hit a lot of different marks, and sometimes that's a positive thing. Used in a lot of different medical uses like neuropathic pain, migraine prevention, etc.
Yeah, that's a great
Brings us to
summary.
the end.
I like to summarize what I just learned today. I learned that these medications go far in history. I also think that bringing up the suicidal risk assessment was an important thing. It's forgotten is that sometimes we don't think about how depressed someone is, that they can't have energy to act on their suicidal thought. And so doing that risk assessment is really important because you can see if they have started the steps towards intentionality, like thought process of the plan. This medication, if used for an overdose, could kill you.
They don't need much.
And then the other thing about the drug interactions or things to consider, I think it's important as clinicians to keep on doing the drug interaction checks. I do Medscape, UpToDate has one. I do. You're on other medications other than psychiatric medications. Let's just do a drug interaction check. And I do it in front of the patient because I want them to know that I'm doing the whole picture and for them to be advocates on what they're taking. I don't want my patients to not know why they're taking X, Y, and Z medications.
Absolutely. Yeah. All right. Well, this is our first mini mindset. We have so many topics. I think between we can present
I know.
like 20 different spinoffs, right? Maybe our listeners can chime in and tell us what they want.
Anyways, well, I hope you guys enjoyed the Mindset Mini. Let us know what topic you want us to talk about next, and we'll see you on the other side.
Bye.
Bye.